informal. You guys are going to be touching, feeling, seeing everything, because this is all that we have back there, and plus some. So just a little small sample of what we use back there. I'll also kind of go over why we choose like an LMA versus an ET tube. If you've ever wondered why, like why do they use that versus this? Like, you know, what's their rationale? So, and then things to look for after your patient gets dropped off, because they might be fine, have their natural airway, and then they decompensate all of a sudden. So, you know, there's things to look for. So first we'll go over just mask in general, like in nasal cannulas. You guys are all familiar, you know, most patients come out with the nasal cannula, okay? Most of them come out with that. We also have one that has an end-tidal CO2 detector on it. I think you all have seen those, okay? And then there's your mask. There's your simple mask for those that require a little more oxygen than what a nasal cannula can provide, or if they're mouth breathing. You've got somebody, the mouth's open, or they're edentulous a lot of times, or if you've got to sit there and keep doing this, you know, do a little jaw thrust or turn their head, best go ahead and put one of these on them. So just kind of help keep that oxygen flowing. Sometimes they might need even higher concentrations, you know, 60, 70%, and you might need to put on, you know, a non-rebreather on them. So this is, but they're got to be spontaneously breathing and kind of aware of their surroundings if you put one of these on. So they breathing patients, all these breathing patients, okay? I don't know if you all are familiar with these palm masks. I've used these sometimes, like for the TEEs, because you can cover their nose and their mouth, give them a high concentration of oxygen, and the cardiologist or GI fellow or surgeon can scope through, there's holes, there's two hole areas, where their nose and their mouth. We can cut out that around their mouth, and they can put the scope through that, okay? And it's still delivering all of that oxygen to the patient. You can measure their end-tidal CO2, the little spout here, and it comes with everything that you need. This is all inclusive, so I love these things.
Now, does that have a dial, or is that driven by your?
It's driven by
your liters,
by your oxygen meter, your
okay.
flow meter. Yes, yes. All of these are driven. Yes. All right, and then I think we got asked about T-pieces, and this is what it looks like. This is how it comes packaged, and we'll open this up and show you what it looks like. Okay. Sometimes if they still have an ET tube in place, we may bring them out on one of these if we're kind of like, oh, they're close to getting extubated, but they need a little bit more time. The patient has to be spontaneously breathing. That's the most important thing. They use these upstairs, like when they're trying to wean somebody from the ventilator. They'll do spontaneous breathing trials. They'll use one of these T-pieces on them. This other thing is called a Jackson-Reese. This is how it comes out, okay? This is also used for helping them wean, you know, get the ET tube, get them extubated. And they may come out with this. So they may come out with this, and they come out with this, okay? With this, you can attach, where's my bag at? You can attach the reservoir bag. This is what we have back there. This is on our anesthesia gas machine. This is what we use back there. You can attach this to it, and you can see the patient breathing. This thing will insufflate on its own, deflate, insufflate. So it's a good thing, because you can glance over, oh, my patient's breathing, versus this, you can't tell. So I prefer this. You can also put a little bit of positive pressure. It's got a little valve on it. So you can kind of help the patient there with that. Help it so they don't, their end-tidal CO2 doesn't climb. I know sometimes when I drop patients off, I'm like, they might be spontaneously breathing, but they may need a little help and, wake them up so their end-tidal CO2 is not climbing. Because if they get too high, they're going to put themselves back to sleep. That end-tidal CO2 gets too high.
So you would say if they have that, you would want to go ahead and connect the end-tidal.
Connect to an end-tidal CO2 detector, because that way you can tell. And you may give them a little assistance. Go over, give you a little assist. They might be spontaneously breathing, but you may give them a little assistance, just like we do back in the operating room, just to help them.
How many liters are in that bag? So you can kind of estimate by looking at how much.
I usually put this on like 15 liters.
Okay.
Crank it up to 15. That way, it's 100% right there. But you can also adjust your valve too.
Okay.
You can put like a little positive pressure on there too. So, and this is attached to your ET tube. So when they come out, that's attached to your ET tube like that. That's inside the patient. Looks like that. Okay. And we'll pass all this stuff around. You can touch it, feel it.
And CC, is that like a ambu bag volume wise? Because that looks bigger than. So you said you can look at that and see how much they're breathing volume wise. So
It'd be kind of guesstimate.
Yeah.
I mean, if they're taking like huge tidal volumes, you can tell versus
Okay.
like very shallow
Okay.
breaths. But the most important thing is they're spontaneously breathing, and you can see this bag insufflating, desufflating. Versus the T piece, you're not going to see that. So
What's the name of that again?
the Jackson Reese.
Oh, okay.
Yeah, Jackson and Reese, R-E-E-S.
And they're rich on the beach.
Sure.
Fiji.
But it's more of a visual. So if you're glancing at your patient, you can quickly see. The hospital I came from, we use these a lot. If your patient's close to getting extubated, you've reversed their paralytic, they're spontaneously breathing, they're pulling good tidal volumes back there, but they're just not ready yet to get that ET tube out. They still may have some low gas on board. They just need a few more minutes, but you want to get them on to PACU. This is what you can use. Okay. And this is mainly the size I use a lot of 7s back there. All of y'all would take a 7. And for your ET tube, we have 7.5s, a little bit bigger diameter. Males usually take an 8, 7.5 or 8. We have all the way down to 5s back there, like for Dr. Burkhart's cases. We'll put in a smaller ET tube if she's going to be lasering or getting around the vocal cords. She wants a smaller ET tube back there. We have anywhere from 5s, 5.5s, 6, 6.5s. I think all the way up to 8.5s back there. Okay.
So you don't want to put like a 7 in a guy because it's too small, and that would do.
Yeah, you look at like their kilogram weight, and you also look at their size. Now, obviously, if you had like a 60-kilogram guy, you can probably put a 7 in. Because the bigger this is, the bigger that is, the sore throat they're going to have. So you may have patients, oh God, my throat's so sore. That's probably why they got, looking at that diameter of that tube that's going through their vocal cords. So try and be, try and get away with what you can, but you also got to look at the size of your patients. If you're going prone back there, sometimes fluffier patients, I want a bigger ET tube, especially if I'm going prone. Okay. Moving on, these are called LMAs, laryngeal mask airways. We have 3 different sizes, 3, a 4, and then a 5. Most females, we put a 4 in. Guys, we do a 5. But then again, looking at your patient, you may have a smaller fella. Okay, well, he takes a 4, because again, that's a big honk. That's a huge size going in their mouth. It's a supraglottic, so it sits above the glottis there. So again, with an LMA, your airway is not going to be protected like your ET tube is. ET tube, you got a guaranteed airway. With an LMA, you pick your patients, you look at what kind of surgery they're having, and go from your size from there. We have smaller ones, like for peds, they'll have, 1s, 1.5, 2s, 2.5s. We start at 3s here. So
those are by kilograms though, right? And it has it on there.
Is listed on here for an easy down and dirty. You can look at here and see, oh, well, that's going to take that. But then again, sometimes, you look at your patients. Okay, well, they might not need this big a size. If they're edentulous, especially, they're going to have a lot of gapping around there. They're not going to have their teeth to help hold it in place back there. So again, just size. And there's techniques. People have all different ways to put these in. I like to use, lube it up really good, water-soluble lubricant. And I have to use a tongue depressor to get these things in. So, and you got to think, they're in probably this far. So all this is inside there.
But
So
it's still above the epiglottis.
Mhm. It's still above that. So their airway's not protected. So there's a risk of aspiration. So therein lies, why would we choose this over a secure airway? Well, is it going to be a short case? Are they an average sized patient? Do they have reflux? That's one of my big things. Do you have reflux? Is it controlled? One of the questions I ask my patients, do you wake up in the middle of the night with reflux? If they say, yeah, okay, then you're not getting one of these. Because obviously you're waking up having reflux come up the back of your throat.
Mm-hmm.
And if you're laying supine like this, flat, there's increased risk of that.
Mm-hmm.
If the surgery is several hours, like more than 2 hours, the recommendation is not to use one of these because it increases the risk of sore throat back there, increases the chance of aspiration. Another name for LMA is let me aspirate, if you've never heard that. Like I said, you can never go wrong with a breathing tube. You're never going to get shush for that. This will always be, if you have to make a choice, choose this. But, you know, you can get away with this. But there's certain things we look at back there. You know, the type of surgery. Are they going to be supine? Okay, yeah, we can use that. If they're going to be lateral on a beanbag, no, I want a secure airway. If they're going to be prone, I want a secure airway. Beach chair position, I want a secure airway. If there's any times like, let's see, my train of thought go.
I guess with manipulation or transferring your patient from one position or another,
Right.
you wouldn't want.
Also with these, if you put one of these in, you have, you know, they're supposed to slip in pretty easy. You should never like shove one of these in, because then you run the risk of bleeding, airway trauma, more chance of a sore throat, more chance of them aspirating. It should always slip in kind of easy. These eye gels, they kind of mold the patient's, you know, pharynx, oropharynx. It may take a couple seconds back there. Plus, you want to make sure you're getting good tidal volumes. If you put one of these in, you're getting like 50. That's not good, because you're not ventilating your patient. If you put it in, there's any signs, you know, of, you know, you think that they're going to aspirate, or they're just not tolerating it for whatever reason, or if the surgeon just, oop, I need this patient paralyzed. I thought I told you that. Then you're going to be like, I need to switch to this, because you shouldn't paralyze with one of these. Okay, that's against manufacturer recommendations. You shouldn't use paralytic with these. With this, you can, with a protected airway. Because once you paralyze, you know, there's increased risk of aspiration. Now, saying that, these LMAs, they do have a little side port. We'll pass these around. You can put a suction catheter through there. These are a little bit different. Other ones you can't do this with. But they're also cuffless too, so you can't insufflate to however what size you need. Like these. These have a cuff attached to them. So you can tear this off, you can insufflate however much air you need to seat this. These seat automatically in there. But, you know, there's other things, risks that come along with it. But, like I said, if there's ever a chance you think, oh my gosh, I think I might be trying to aspirate, you can put a little suction catheter, a little skinny suction catheter through there. That is one nice thing about these, okay? We don't normally use this time, it's an air cube, but it just shows that you can put air in this and help it seat better in there, okay? I think that's all the airway stuff. I do have oral airways we can talk about. You guys have these in here, right? We have different sizes. We have an 8.0, the 9.0, and the 10, okay? Most females can take an 8. Do you all know how to measure to make sure? You know what size you're putting in? Yes, yeah. From the tip here back to their ear, or if you're gonna do from the middle of their mouth, like to their jawline. Okay, kind of the same way for a nasal airway or a trumpet. But these also help you as well. More so if you're doing like a MAC case, like a sedation case, or say we've extubated and they're just not, you know, I'm a little iffy about their airway. I'm having to give a chin lift jaw thrust. I'm having to adjust their airway. They're trying to obstruct on me. Their tongue's falling back. You can put one of these in, okay? But if they're in any way aware, they will not let you put this in.
So when she
yes.
says measure,
Yes.
sometimes this is all I do. Like go like
Yeah.
from here to here. Or, you know, and then like, oh, that looks like about the right size. If it's not the right size, it won't get the tongue out of the way. But
Right,
if it's
and you
down
need
there,
the tongue,
yeah.
because that tongue is
Yeah.
falling back
Yeah.
onto their airway, occluding their airway.
Well, you're going to demonstrate maybe to put one of those in.
Yeah.
Okay.
And these are pretty easy. They should just kind of slide in. And if you're, you know, kind of in a semi-awake patient, if they start coughing, you know, you may need to go down a size, or they need to be a little bit deeper. It just depends.
I know on the weekends,
Yeah,
like,
you
we
kind of get a
don't-
feel for it.
We don't have the color-coded ones,
Oh.
and we
Oh.
needed a larger one over here one weekend, and they had to go to surgery to get it, because, so I don't know if we could stock some of these
Yeah,
color-coded ones
Because
over here,
these,
'cause we don't
I can
have
look
these.
at them and go, okay, that's an 8.
Yeah.
That's a 9. That the red's a 10. I know just by looking at the colors.
Yeah, so it'd be nice to have
Yeah.
some of those.
And
Okay.
I feel like those are easier to put in and they're softer. The other ones I
Yeah.
feel like have a different angle,
Yeah.
different angle on them that are
Right.
harder to put.
You just have to be leery about if they've got any loose teeth, because they can chomp down on these, break their teeth, snap their teeth. So just be careful, you know, putting these in. Here's nasal pharyngeal airways. Same way, measure from the middle of the mouth to the jawline, or if you're going to measure from the corner, then back to their ear. Okay. We have different sizes. We start with a 26. That's like a little bitty one. Make sure you always lube it up really good before you put it in there. And make sure your patient's, you know, not aware that you're going to shove this in there. It goes in pretty far. You're going to fit it to the flange there. We have 26s all the way up to 34s. Yes. So here's a 26 and a 34. You can see how big the difference is. Okay. But you want it sitting right where the pharynx is. You don't want it back any further, because if it is, you're going to start coughing because it's touching back there, and it's very uncomfortable. You can also suction through those too if you need to. All right.
And a
But
lot of
this-
times we teach from the nose to the tragus too. So it might be
Yeah.
2 different ways to measure.
Right. So yeah. So this, you know, this guy, you know, from here to here. So he might need a little bit smaller. one.
Yeah.
Yeah. Well, you have different sizes. Usually the right near is the one that you use because it's going to be in perfect position with the correct size, right where it needs to be, right there where the pharynx is. The left you can, but it may need a little further. So it might, and sometimes I put them in, I got it sitting out just a little bit. So it just, like I say, your patients come in all different shapes and sizes. So you may have to put it, and I always like I said, make sure that their nose is, you can lube this up pretty good, you know, lube this pretty good. The only thing is these are made out of latex. Well, just be sure these are natural latex. So that's probably the only thing we have back there in the OR that is latex, besides gloves. So just so y'all know. Okay. And then make sure, one thing I look at too before I put one of these in is, are they on blood thinners? Are they currently on blood thinners? Are they have an increased risk of bleeding? You know, because you don't want to put one of these in that cause a nosebleed. Make it worse than it already is. Because then you got another issue to deal with. Okay.
What did you say was the reason we would use a nasal trumpet over the oral airway?
Sometimes it just, like I said, it just depends. I mean, provider preference back there. So, but I'll look to see, you know, are they on any anticoagulants? Am I going to cause more trauma to their nose by doing that? How deep is their sedation? Because a lot of times we'll use these in MAC cases back there.
Okay.
And it just helps, you know, with your, you know, oxygenation, ventilation back there. Okay.
So if they bring out a patient and they're obstructing, which one of those would you choose? Because I would probably go for the oral.
Yeah.
Because most of the time it's a tongue thing, right?
For most times it's a tongue thing. Yes.
So-
and when they're awake, they're going to be like, they're going to be able to get this out.
Right.
You know, this, they will tolerate this.
Kind of keep, yeah.
They will tolerate this probably all the, you know, as long as you let them. They, what's this? Finally, what's this in my nose? But with that oral airway, they're gonna be like, oh, what is this? I want this out.
Yeah.
So
Okay.
that's probably, you know, if you're kind of on the fence, let's just stick an oral airway in. Maybe by the time we get to PACI, we can take this out, and they're more awake.
And in the back, you guys might make a decision one way or the other.
Right.
Okay.
Yeah. You know, some people, like I said, it's just provider preference, but that's things that I look at back there. I was born with the anticoagulants if they're on that. So sometimes you can also put one of these in and hook the end piece off of a end-tidal or a ET tube. You can take one of these, put it on the end of this, and you can hook up your breathing bag. You can get positive pressure ventilation in a MAC case.
Is that something that you guys do frequently, or?
No.
No, okay.
But
Have
you
you seen
can
that?
in an emergency. I did it sometimes in endo when I've got, you know, patient that's desatting, you know, they've got a nasal cannula on, or I'm trying to, you know, need to put one of these in. This will a 7.0 off the end of an ET tube will fit perfectly in there, and you can hook your ambu bag. You can hook an ambu bag to it. You can hook your anesthesia, your reservoir bag, this bag to it, and you can give a little positive pressure just to keep those airways open. So lots of little things, you know, little tricks we use to keep that airway open. Let's see. I can demonstrate how to put in an LMA if you want, and we can. I mean, you are ACLS certified, right? So that is within your scope. I mean, if you need to put one in over here, you know, that's something that we can do.
To put in
wasn't
the
sure.
LMA?
LMA, yeah, because it's learned in ACLS as part of the algorithm. So
I wasn't sure if his mouth would open.
I know.
I think it would
And
be
I
really
like that
tough.
little thing there, especially when you're talking about the LMA where it sits.
Yeah.
That thing would show you pretty
so
well.
It's supraglottic, so it's above, you know, your vocal cords.
there.
We'll leave this
Wow.
stuff here, and that way they can
Yeah.
see all this.
And I think
Did
everybody
you feel like
came
you
out.
got through a lot? I know she's got to take nurses to do some.
I went
Yeah.
explained everything, but
Yeah.
I can demonstrate
Yeah.
on him here.
Yeah.
Yeah. Especially with like the Jackson Reese, like it's what they come
Oh.
out. So we can intubate him here. We can do that.
There's the spray.
Oh, you know, I didn't bring a slide.
Oh,
I might not be able to.
that's fine.
Okay.
I don't know. Here,
Oh, and I didn't get over the
let me get a napkin.
what to look for your
Paper towel.
extubating.
Mm-hmm.
Yeah. And I'm recording,
Oh,
so
okay.
anything you say, they're gonna
All
have
right.
access to.
So like, well, with extubation, some patient comes out with the ET tube still in place. They've got this Jackson Reese hooked to it.
Mm-hmm.
You can see they're spontaneously breathing because we wouldn't bring a patient out that is not spontaneously breathing with this on. That's your patient needs to be spontaneously breathing. If not, they need to be attached to mechanical ventilation, and we will call for respiratory therapy to have a vent ready to go and let you all know that. But if they're closed to extubation, you're watching, you can do a leak test. Do you all do that? Do like a leak test? You can let down the cuff and see if you can hear them breathing around that. And there's a formula you can use. It's got to be greater than 15%, and you can safely, quantitatively say, hey, this patient is ready to be extubated. There's no airway edema, I believe, because that's the biggest thing. Because you don't want to extubate them and then, oh gosh, we have to emergently re-intubate because they're going to be more swollen in there.
Especially for prone cases or thyroid cases, any of these head and neck stuff that we do.
Carotids.
Yeah.
Yeah.
Yeah, I'd be especially concerned with, like she said, with the neck. I would be like, if I had a concern, I would be calling you guys.
Yeah.
I don't do leak tests. Have
Yeah,
you?
no.
Yeah.
We don't do them a whole lot.
Okay.
anymore.
Yeah.
Very much. Yeah, I don't know where the.
Oh, I had it on here. I was showing them. I was showing them where we could put, if you're an endo or you're doing a MAC case, you put one of these in, you can put this, attach this in here, and you can give positive pressure ventilation through this.
Yeah.
Yeah.
Look at how his
It's a
chin
little
comes
trick.
up. That's pretty awesome.
No, I don't know about an ET tube though.
Are we gonna tolerate one?
No.
Or could we put it through here, maybe?
Maybe with a McGrath, huh?
Yeah, I brought the McGrath too. Yeah.
Yeah, supposedly he's intubatable, is what I've heard.
Okay.
Let's see. I don't have a blade on there, but
Oh,
it'll
I
be
said I have a
okay.
blade too. if you want this
Yeah,
one.
I don't think we have to.
So that's the McGrath. That's what you're
Oh.
visualizing. These are different blades that we use.
It's
Oh, there you go.
interesting. Oh,
You
there
see
we
'em?
go.
There they are.
Yeah. It's like,
Do you see,
okay.
Morgan?
Yeah.
She's
well,
like, hand me the
kinda.
two.
Well, I'm off to the side, which is weird, but there we go.
Yeah.
Maybe he's crooked down there.
Do you need some cricoid pressure?
Oh, is that what it? I mean, maybe that's what the core there. I feel like I'm getting a lot of. I don't know. Maybe because I don't have a.
Stylet.
Well, maybe because I don't have a.
Oh, the blade on
Yeah,
there?
I don't
You
know.
want the blade here?
Yeah,
We can just-
I don't know.
And put this
This is
on
why I'm
there.
gonna put it through this one.
We have 3 different sizes of
Here, we'll
these.
go
We have a
for there.
3, an X3, and a 4.
Okay.
There we go. There we
Just put it over
go.
there. Okay.
Nice.
There you
It's not
go.
going to insufflate the lungs, though. There we go.
Yeah.
But that's okay. We'll see again.
Of course, and
I've
then you
never
blow up your
intubated a
ET
mannequin.
tube here. All right, we just kind of feel it. Okay, and that's good there. Okay, the cuff's inflated
Okay.
there. Just kind of feel. You don't want to overinflate it because you can cause damage to their trachea. You can
Oh,
cause
mannequin.
erosion of that,
See,
bleeding,
mannequin,
trauma,
open
all
your
those
mouth.
things.
Oh, looky there.
Okay.
Oh,
See.
looky
Say, is it a good sniff? Oh, here,
there.
it's inflated
okay,
here.
Gotcha.
We're not going to tell you what she thought this looked like earlier.
Don't forget, for Employee Appreciation Month, we have Hurricane's food truck here from Oakley.
Let's see if we can
So
do
there's
it
your vocal
without
cords.
without the stylet. I don't know that I can,
can
do it
open up
without
the
the
original one
stylet.
without.
I know.
Here.
Oh yeah.
That's
All right.
very
Yeah.
nice.
I know. I didn't know.
Didn't know there's. What is that called?
McGrath.
That's
Yeah.
pretty
McGrath.
cool.
We have these in every room back there, and then this is a rigid stylet.
Do you always use them?
Oh, McGrath.
Yeah.
Some people do.
I feel like that makes it. a lot
It's
easier.
kind of it's
There.
another airway adjunct that we use if you're
I feel
having
like you're in there too
difficulty.
deep. I know. Like, look at me struggling. I know, man. I
And then come back.
Yeah,
There you go, you're right there.
I know. It's like, whew. You see? I know. Come on, man. I can't do it. I don't think I can do it, Kim. There.
Or here,
Ah.
can you pull back.
Yeah, maybe.
Here, you go.
There we go. Intubating a mannequin. This is like real life.
Like,
There
give me
you
a real
go.
person.
There
See,
you
it's
go.
right. See how it's going through the cords right there, and then she's gonna pull the
Yeah.
stylet And then we're gonna just
Nice.
push this on
I know.
through. Sometimes
I was gonna say, how,
Yeah.
you may have to twist it a little bit.
Well, you had.
Yeah.
Oh, we
So
were
like-
deflated.
Uh-huh.
Okay.
Sometimes, well, that's sometimes what you have
Yeah.
to do. But then you gotta twist it a little bit, or you gotta
Yeah.
have a little crickway pressure. And then, where's my syringe? We're gonna blow this up here.
Oh, here it is.
So we're gonna blow, and we're gonna pull it back to.
I was gonna say, how do you know how
So
far?
that's a 7. So, 22-ish or so, right
I
there.
bet if you're
But we
in too deep,
listen.
it would only
Yeah.
like.
The right side. You know, it'll go down.
But
the
you know,
right
you're gonna
side.
listen for bilateral breath sounds, chest rise, your end tidal CO2 back there.
And
And we can
here,
attach
let's
this.
see. Yep.
Attach it to the oxygen there. Yep. There we go. Okay.
So this is what's interesting to try to get used to,
Yeah.
because if it's
It's-
open or closed, this will fill up and it's almost too much pressure for the patient to
If that's
to breathe.
closed,
Or,
it'll
breathe.
get really
Yeah.
huge.
Okay.
Yeah. So it's almost too much pressure for the patient. So you kind of have to play with this valve.
it.
Now, what does this valve do?
It just opens
Like a
and
pressure
closes.
valve.
Like
Okay.
yeah. So it kind
You
of
can deliver positive pressure to the patient.
Yeah,
It
so
actually
you know, like
works.
an ambu bag, there's nothing. It just kind of keeps collapsing. So it's kind of like got its like where you can put a little PEEP valve on it, where you can actually build up enough pressure to help the patient to
So when I say, you just kind of walk it, listen, look at the patient, give a little breath. That's what
Yeah.
you're doing.
Okay.
When they're spontaneously breathing, so you can see this bag insufflate, deflate, but give
Yeah.
a little,
Okay.
little extra
yeah.
help.
But you guys will have this set when they come
Yeah.
out. So
Yes.
basically,
Yeah.
they're going to make sure they're taking sufficient breaths with that.
Yes.
Yeah.
Hook them up to end tidal,
Yes.
and then we wait for this guy to wake up. And how would we know he's ready to extubate? What would we see?
You won't make sure if they've been paralyzed, make sure they've been reversed. Their paralytic's been reversed.
So they'll get in that report.
with either get that report, either Sugamidex or neostigmine and Robenal. Okay. Make sure that the patient is following commands. Make sure that they can give a hand squeeze. They can lift their head. They can wiggle their toes. Kind of little things that we do. Make sure they're suctioned really well. That's a big thing, because you don't want to take this out and they've got secretions sitting right there, because if they get on the vocal cords, there's an increased risk of them laryngospasming. Okay. Let me see.
So are you saying disconnect them here and suction, or just suction around the
Suction
oral,
around in here.
the
Suction
oral
in here.
airway?
The oral
Okay.
pharynx. Yep. Yep. If there's stuff in here, if you see stuff in the NT2, or you listen and they've got rhonchi in there, you can put a suction catheter down in there.
A red rubber or
A red
something
rubber,
like that.
yes.
Yep.
Yes. But just kind of make sure, let's see. Yeah. Make sure that they're hemodynamically stable,
And title's appropriate.
Entitle's appropriate. And first that they need to be extubated. Are they going for another surgery the next day? Has there been any trauma that they're suspecting in here? Do they have any airway swelling? You can do a leak test on here. You can let this cuff down and see if they're breathing. You hear air sound, breath sounds around that, if it's escaping up around the ET tube. I don't know how often. Respiratory would be the one to do that. And they have you can't really, I guess, get your equation per
Manometer.
se.
Yeah.
You can use that manometer to kind of do your
Yeah.
leak test. But as far as figuring out if they're greater than 15% and it's okay, everyone feels, okay to extubate them. But just looking at, the signs, they're hemodynamically stable, they're not on pressors.
So when you bring the patient out and this is in place, you would say, hey, whenever they meet criteria,
Right.
feel free to extubate.
Which is they're awake, they're following commands. Because sometimes, you think they're following, but they're not really. Like they're just kind of they're entitled CO2, and that's important. Why we need to put the entitled CO2 on there. Because if you just let them just sit here and breathe, sometimes if they start breathing, 5-6 a minute, they're going to build that entitled CO2 up. And their brain's just going to go back to sleep.
Yeah.
And I would say, I'm going to pop in here. Hi. I would just always call it the anesthesiologist to make sure that they are
Yes.
okay with you extubating without them present. Because sometimes we could be here, but if we've moved on to another case, I would just talk to whoever's in charge of this patient and make sure that they're okay extubating. And that's just going to keep everybody.
So that you'll give that in report,
Yes.
and then if
Yes.
they ever have any questions, reach out to you guys.
Reach
Is
out
the
to us.
big, yeah.
We're not just to bring a patient out. Oh, here you go. You know,
Especially if you're not
there's-
comfortable extubating, I
Right.
would not pick the day to do it by yourself. You know, we're available, so.
But the thing is, suction the patients. You know, that's because a lot of them have, you know, their secretions. Their, and then make sure before you extubate, you put that cuff down.
So will you show us how would you, can you demonstrate? So
Yeah.
our patient's awake, he's
So-
following commands, his end
Have his
tidal looks
eyes open.
great, he's lifting his head, his vital signs are perfect, and they're like, let's extubate.
Okay.
So what does
So
that
we're gonna
look
say,
like?
you know, hey, sir, take a big deep breath. We're gonna get this out. All right, deflate it, pull it out,
And have them cough on,
and have
yeah.
cough. Well, they're gonna cough.
They're gonna, yeah.
Regardless, they're gonna cough. So and have like your nasal cannula or your oxygen mask ready to go on there.
And if they get stridor, like it feels like they're gonna spasm, because you know, we all know that sound, like, try to get up underneath their jaw. And if you have a mask, like with an ambu, then
This
trying to
or-
give some positive pressure. And sometimes it's hard because if you can't give positive pressure with an ambu, but you could probably put the mask on there and give a little bit of positive pressure.
pop this
But
off.
but I would get up underneath this and try to break it with just getting up underneath their jaw. And I feel like there's a trigger point that I don't know what that's called, but that you can get up under there. And,
right there.
and sometimes they will take a big deep breath, but a lot of times it's just a little bit of pressure
Yep.
on them, get under here, under here, and just enough pressure in this bag that's going to open up, the laryngospasm. If they don't and their sats are low, this is your time to call for help. And then we may need to re-intubate, give some sucks, that sort of thing. So,
I would suggest maybe if you're have this scenario, you're gonna extubate the patient, have like your intubation stuff ready to go, like have the box
Just-
ready to
yeah,
go at
just
the
in case.
bedside, just in case you got to emergently re-intubate them. So just have that available.
So would it be best practice or to let someone know in the back?
Yes.
Yeah.
Okay.
Yeah, hey, I'm
Or-
getting ready to exit. I think this patient's ready. They've met criteria. Do you want to lay eyes on them, or are you okay with me extubating them?
Okay.
Because we're getting ready to. So
Perfect,
That way
yeah.
Gives the staff, a heads up. Whichever
Yeah.
anesthesiologist is covering. Or us. I mean, if we're around. So.
Yeah.
But then also have the intubation box ready to go there too.
but then also, we've extubated plenty of people that meet criteria and then they just go back to sleep and they're snoring and they still could use
You might
an
need to
oral
put
airway. You
one
might
of
have to
these
put,
in,
you
or
might
an
have to
oral
put,
airway.
because they're not annoyed anymore. So now they can go back to sleep. So you may have to put them on a face mask. You might have to just get up underneath their chin.
This is a lot of work on the
So, yeah,
patient.
Yeah.
Would that be
You know?
where you put, like you said, the oral in them and just let them chill if they're
Yeah.
going back to sleep for sure?
If they'll let you tolerate putting that back, yes, put them back. Put that oral airway back in. Put a mask on them. You can turn their head, to the side. It kind of helps open things up too. So.
But it's my understanding that if they have an airway in at all, you're not supposed to leave the bedside unless you absolutely necessary. So just camp out until the patient is, maintaining their sats without snoring. And and some of these patients don't come out with an airway, but they're obstructing a lot that need frequent reminders
And
to
you
take
can
a big deep
hear
breath. Yeah, you
the
all know.
obstructing.
So
Or you have
yeah.
the pleth turned up to where you can hear that pleth start to go down. Because we listen to that pleth, that's part of it back there. So.
Does that make sense about the pleth? I think you had mentioned something
Yeah.
about that. Do you want to share?
Well, just that from an anesthesia perspective, we are trained to the sound. In addition to what we see, we can sort of multitask and be starting an IV or an A-line, and we can hear what the sat and the heart rate's doing. So we use that as part of our daily practice. And when we come over here, sometimes if it's shut off and we're doing a TEE, we kind of, I looked up the other day and I'm like, oh, my sats are 89. The sound wasn't there, so it sort of alarmed me. But yeah, I do think it's a good way to assist your practice and how your awareness.
It's best to intervene early, because some patients might not have the best functional residual capacity. They're going to desat on you, and it may take a while to come back up. So it's always best to intervene early.
And check your alarms. Now, do we have
Check your
standard what
alarms.
we set our O2 sat alarm for in here?
It always will beep at 88. It'll turn blue at 89, but it won't start beeping really until 88.
Okay.
And
And sometimes then they're going off the cliff, or
So
sometimes they're
maybe
waking their
can
way
we
back
can
up.
can we adjust that?
Right.
to at 90.
Yeah, I mean,
start
or
looking
is
at
the
90.
default you're saying is
Ours are
88?
set at 90 back then.
I'm just curious. I'll have to.
Sure, yeah.
Okay.
And I think the other thing to mention, like from a risk management standpoint, if they have an oral airway in, just be very cautious if they're awake, or when you all are removing them, don't just
Gently.
watch their teeth, because we have
It's hard
people
plastic.
with bad teeth. We just need to make sure that teeth are intact, and
are very-
sometimes they bite down on them, or we're trying to take them out
These
too
are
soon.
very pliable.
Especially with some of the endoscopies, they have that bite block in, and I don't think I've ever sent anybody out with a bite block, but just watch, just don't yank it out of their mouth. So, risk management, thanks you.
Because it's in there pretty far. I mean,
Yeah.
that's a lot in someone's mouth, And it's not, like I said, some patients that they will, I'm taking this out.
And also just careful with suctioning, because we have had
Yes.
someone bite down on
Recently.
the yonker and dislodge like a crown on top, and it was kind of,
Be careful poking
Yeah,
things back
yeah.
in there. So
So.
that's like with the LMAs too. Don't ever shove anything. Just whoop, very easy, gently. Yeah. If you're meeting resistance, you may need to change the size. It may need more lube. You may need to kind of do like a little. Let me get you in a better position. So, and that's things we do back there.
And I don't know if everybody feels comfortable with the jaw thrust. I mean, I feel like is that something that you guys
I think
learned?
there are some that aren't.
Okay, so maybe we can work on that.
We can
some.
demonstrate
Yeah.
it like on
I
you.
know.
Like
But if we're having to jaw thrust them, we should be putting an airway in them.
If you haven't.
Yeah, because I've seen people standing there holding, and I'm like, put an airway. I mean, if you want to stand there and hold, that's on you.
Yeah.
But
things
still,
to
you
do,
should
though,
stay
so
at the
that yes,
bedside,
and that's
even.
what's best for the patient.
Yeah.
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 And sometimes it just needs a little.
Or
you
turn their
know,
head. Sometimes turn their head like
Mm-hmm.
this. If they'll let you, turn it like that and give a little. That's what we do back there. Yeah.
I think the biggest thing is if you don't know, just feel free to ask, because we realize that not
Yes.
everybody has the background. I mean, we've trained for years and we've been practicing a long time, and so we just want everybody to feel comfortable, because at the end of the day, it's the patient that we're worried about, so just feel free to ask us, and we're here, we're available, we can leave all this stuff. If you say, hey, I didn't even get the in-service, can I play with this? Let me show me
Touch
what
it.
this
Touch
is.
it,
Yeah, we're good.
We
Yeah.
can open up those LMAs. Just touch them, But that's, they've got, that much of that in their mouth.
Yeah.
That's a lot
Yeah.
down there.
Is there things that you see?
So,
Oh, I'm sorry. I definitely.
Is there things you see or anything you have questions about for clarification?
that
'Cause-
people have come to you about.
Just last week, I was in day surgery with Morgan, and we had to jaw thrust a lady. But she came out, she was talking, she was awake and oriented, and then after a few minutes, she just, I think it was the Dilaudid hit her,
Dilaudid hit her,
and she stopped breathing. Her respirations went up, and her oxygen obviously went to like 60. So I just laid her back, and you heard her go.
Yeah.
Yeah, it is that breath
Because
of
this is
life.
very stimulating.
Yeah.
I mean, it hurts your
And
jaw,
Morgan
your
was
pressure
like, oh my
points.
God,
Right
I'm so glad you're here.
Oh.
We couldn't find a simple mask. We were looking in the drawers.
Yeah.
There wasn't a simple mask.
Yeah.
So
These should be the simple mask,
Airways.
airways should be in all these.
Are
And
they
we can
all
work
in
on
there?
getting the color coded. So that way you can easily glance, oh, I need a green one. It's a, it's a female.
And some of these
Yeah.
patients have zero reserve. Like
That
they are just
functional
what I
nasal
say.
capacity,
It's
they're
just
gonna
like they're
drop.
standing right on the cliff, and as
Yeah.
soon as they go over, then they go from 92 to like 70, just like that. And
Best
so
to
it's
intervene
just
early.
So it's like, why did they were just at 90? What happened? And it's just their the oxygen dissociation curve, which is a lot of
Yes,
like
that's a whole nother topic. That's
I know,
another
but that's
day.
basically once they go over the
But
cliff.
if you've had to give
Yeah.
narcotics, if you've had to give other things
Yeah.
impact you, it doesn't take that long. When that it kicks in, that medication kicks in. That's why we say we can't. You're hurting, but we got to gauge how much we can give you. We can't,
Breathing's
knock
important,
you out.
yeah.
Breathing is important. I got to have you breathing.
That's why we do a lot of multimodal stuff, which is great. So
Yes, the
I
ketamine,
know.
the magnesium, Presidex.
So did you have to
practice.
put an oral airway in her, or did you just do a jaw thrust
jaw
on her?
thrusted for a minute, and then she kind of woke up after that and stayed awake and didn't have any more issues with her airway.
But
yeah,
a
she
lot of
definitely
patients
obstructed.
would benefit from a simple mask. We don't bring them over as much, but sometimes if they're mouth breathers or they're not getting it, it just delivers a
This'll
little bit
cover
more
their nose and
oxygen.
Yeah, I've seen them like
So-
take oxygen and stick it in their mouth, and I'm
Right,
like,
right.
that's great
Yeah.
too. But
Yeah.
if you need a mask,
But if
put a
you
mask
think
on.
about
Yeah.
it, if they're
Tongue's falling back.
obstructing and then they're going
That's
through
not
their
gonna
nose,
help.
we're just blowing it up their nose, but is it
Exactly.
really
That's not
going
gonna
anywhere? So
help.
sometimes just having a little bit more oxygen, and if they cough, then it kind of covers that too. So anyway, but just and you all have those available. But
Any other things, issues, concerns, questions?
Oh, I have another comment about
Oh,
a
I
young
love
boy
this.
that actually had a laryngeal spasm, we think, because of the oral airway.
Oh.
He was like 16, I think, and I think it was just maybe where it was, but that's what he was. It might
Didn't
have
we call a
been-
code on him or wrap it on him?
Yes, and we were
did.
in day
yeah.
surgery. Yeah,
I remember
and-
that. Yeah.
Oh my God, that was my patient.
So how would you all handle that?
well, it's because
We took it
probably
out.
got down on
Got-
the cords.
and
yeah.
too finally
Down in the
Yes.
pharynx. It
But
was
it's
get it
scary when young people have a laryngospasm because it can go into a negative pressure pulmonary edema because basically they're trying to breathe on closed vocal cords, and so things happen in the lungs and then they just get flash pulmonary edema.
Yes.
So they start coughing up that pink frothy, and it's scary. I know it is scary. So, but young people are a little more, I think, a little more
Resilient.
prone to,
Yeah,
well, they're prone to laryngospasm.
prone to that,
yeah.
yes.
But-
Especially young males.
Yeah, yeah.
That's what
so
they,
the
that's what- I think
suctioning
it was
is
Dr.
important.
Lay. I think
Yeah.
that's what he said.
Yes. So.
But you know, remember, you take out just give them positive pressure. You know,
you got-
maybe a little bit of propofol sometimes
Yeah.
will break that spasm.
Yeah.
If we were back in the OR, turn the gas up, try and break
Yeah.
it, or a little bit of sucks if you have
Yeah.
to. Last resort, give them sucks to break that. You know,
And it's just
Spasm.
clamped.
or clamp down.
But was he awake or he wasn't
was
awake?
not awake.
See, I would be
There's
concerned if
sounds
he's.
that they make. They start making that.
Yeah, that's
Oh,
what it
Lord.
was. Like he was
You
gagging
hear
on the
that, you're like,
airway.
oh, because if I hear that back in the OR, I'm on it, like trying to adjust their mouth, just give a little positive pressure, especially if I've just extubated.
Yeah.
You know,
But he had LMA in.
But he had the oral airway.
he had
Yeah.
The
this
oral,
release,
yeah.
and it was probably just a little bit
Too
it slipped a
long.
little too far back, and it hit his pharynx and just tickled it.
Yep.
And yeah,
That's what
There you
spasm.
go. and that's like with secretions. That will cause. Make sure you suction patients out. You know, get all the secretions out.
That was a good.
Yeah, this was awesome.
Well,
Yeah,
thank
if we
you.
can keep all this stuff over
Yeah,
here.
totally. You can keep-
Do you
yeah.
want to, because I think I took pictures, but do you want to just kind of run through these and I'll just video the different close up?
Well, we can start with, let's see, the nasal cannula down here.
Okay. The two
The,
different
the simple nasal cannula. And then this one has the end-tidal CO2 detector.
And
on
how
it.
much oxygen can you run through those? Up to how many liters?
That's if you're getting past, if you're approaching 6 liters, 8 liters sometimes, then you need to go ahead and switch to a mask.
Okay.
Because that will cover your nose and your mouth, and you can give more oxygen through that. But this is what we bring patients out a lot of times that have had general anesthesia. We'll bring them out on a nasal cannula.
Okay.
Just because they're still waking up from surgery, general anesthesia. So, this is just a basic simple mask. I usually 4 liters. I'll start at that.
Okay.
This is the non-rebreathing mask.
Okay. And what makes
there.
this a non-rebreather?
Well, patients they have to be spontaneously breathing to get this. If they need a higher flow, if they need more than 60 to 70%.
And we got these little flaps right on the side.
Yes.
And then
it
it's
comes
got
with the
the
bag,
bag.
there. It comes with the bag inside there. So basically, your room air is 21%. This, if you're given 4 liters, you're like 28, 32%.
Because each liter's 4%, correct? Okay.
Yes. So with this, if you're having to give a lot more, but they're still spontaneously breathing, but they need more oxygen, this will be 60-70% starting out.
Perfect.
So you can crank this one on up. This palm mask, it requires a 4-liter flow to start. This covers their nose and their mouth as well. There's also holes in there that you can kind of cut out, perforate, where if they're needing like an endoscopy procedure, like a EGD, even for a colonoscopy, or a TEE procedure where they're going to be putting a scope in, you can cut this open so the endoscopist can put the scope, or the cardiologist can put the scope through there, the bronchoscope, or the scope.
And that's where you can connect the.
You can connect the end-tidal CO2 right there, and it comes with that. It comes with the end-tidal CO2 tubing right there. It also comes with a mask too, so if they need to, breathe in more there, they can have more oxygen there. This piece right here, this blue piece, connects inside here, which connects to your oxygen source.
Okay.
Everything comes with this. All you need is your oxygen source.
Perfect.
With this. So pretty simple to use. Your more obese patients, fluffier patients, this is a lifesaver. Just because you can get more oxygen covering their nose and their mouth.
Okay.
This is the T-piece. We talked about if they have an ET tube in place, we can bring them out on this. However, there's no bag to put on here. You just have an oxygen source. There's the Venturi that you can, if we have those, then you can control how much oxygen they're getting. This is more of like for ventilation weaning trials, spontaneous breathing trials.
So once again, looking at your end title, making sure
Right.
that their oxygenation,
Mhm,
their worker breathing.
Ventilation, but this, like that, they have to be spontaneously breathing. We wouldn't bring out that patient's going to be on mechanical ventilation for one of these. That wouldn't be appropriate. Jackson Reese's, those are the next thing. This is what you're probably going to see with a patient that has an ET tube in place. It comes out like this, and from the bag, you have this here. You can attach the reservoir bag to that, and this will insufflate and desufflate based on the patient's respiration. So when they're taking breaths in, you can see it collapse. When they're breathing out, you can see it fill up. You can also set your valve here so that you can put a little positive pressure. If you close it all the way, the bag's gonna fill up. If you kind of leave it, and you kind of have to play with it a little bit, but it just kind of helps keep like a little auto peep on the patient, kind of helps keep the airways open, help keep from collapsing. This is also in a spontaneously breathing patient. Patients who need a little bit more time with the ET tube before you extubate.
Now, is there a minimum amount of liters that needs to be going through that to keep that going?
I usually put them on 15.
Okay.
Yeah, 15 here. And this attaches to your ET tube. This piece right here. So this would attach to that. So this would attach like that
Okay.
to your ET tube.
And she showed us about extubating, so that's
Yeah.
good. Okay.
Make sure you take your cuff down. Most importantly, before you extubate. Okay. We talked about the different sizes of oral airways. We've got. Where's my other one? Oh, here it is. We've got 3 different sizes that we use. They're color coded. This would be an 8, 8.0. This would be a 9, the yellow. They have the sizes labeled on there. And this would be a 10 or a 100. I'm going to be upside down. Okay. And then to determine what size you need, most females are going to need this size, maybe this size. Most men are going to need the larger size. But again, it just depends on your patient. They come in all shapes and sizes.
And we talked about measuring from here to here, so
Yes.
you guys showed that pretty good.
The corner of the mouth, back to the end of the mandible. Okay.
Okay, good.
And these are hard plastic, so be wary about your patients who have poor dentition, loose teeth, because you don't want them chomping down on this and risking breaking a tooth.
Good deal.
We also have the nasal trumpets or nasal pharyngeal airways. Different sizes 26 all the way up to 34. They look like that. They are made of latex, so be leery if you have a patient with a latex allergy. We talked about how we measured these, measuring from
The tip
tip
to
of
the
nose.
tragus, yep.
Most people will use the right nair for the diameter size that you're going to need. Make sure you lube everything up before you insert
And twist.
anything.
Twist and
Water
lube, yep.
soluble. And just be leery too if your patient's on any blood thinners, because it may cause bleeding, may cause swelling. They may have a sore nose afterwards. So just be mindful of that. Okay. We talked about the different size LMAs. We have 3s, 4s, and 5s here. They are labeled with the kilogram weight they're suitable for, but then again, size your patient up. They are a rescue airway adjunct, so if you have a patient that's decompensating, you need to insert an airway, this would be appropriate to insert. It does sit supraglottic. There is no cuff to inflate for these. They kind of mold to the patient's mouth, pharynx area. But there also is risk of aspiration. But you can attach these to like an ambu bag. You can attach it right there. Okay. This will connect right straight to, or we can also attach it to this, to a Jackson Reese. All these things are kind of interchangeable.
Okay.
You can also, if you need to suction too, there's a little gastric suction valve right there. These eye gels have that.
Okay.
So you're able to do that with these. Okay. And they're just a little, when deciding like between an ET tube and an LMA, there's different reasons why you would pick one or the other. Both have their pros and cons. But again, size your patient up, what kind of surgery are they having, what position they're going to be in, their medical history. Do they have reflux issues? Do they have gastroparesis? Have they been NPO? Is this an emergency? You wouldn't want to use those in an emergency.
And you talked about positioning and all that too as well. Yep. Okay.
Positioning and just kind of, you never want to shove. This is a pretty big, it's a soft, pliable plastic, so to speak. But you never want to shove anything. You always want to lube everything up really good before you'd insert that.
And then ET tubes, of course, they'll already have those in place.
Different sizes, yes. The majority of sizes we use are 7, 7.5s, or 8s, based on the diameter of these tubes. Of course, the bigger the size, the bigger the diameter is. And they have a balloon that you can inflate with those.
And then documentation, they're good about that, to document where at the lip.
Document where it's the lip.
Yeah.
And you always want to, you get bilateral breath sounds because you don't want to, have a patient that's main stemmed, where it's too far down. The tube is too far in, and then you're only ventilating the right lung. You want to make sure you're ventilating both lungs.
Okay.
So you may need to just, if the patient does have one of these, you may want to make sure you've got equal bilateral breath sounds, and you've got end-tidal CO2 to make sure that it's, because anytime there's a position change, I know back there if we go from supine to prone, always re-listen, because your tube can, migrate, it can come out, it can do all sorts of things. So you always want to listen with a stethoscope. And make sure your tube hasn't changed.
Perfect. Well, thank you so much. This has been awesome. We appreciate it. And we get to keep all these goodies to have them put hands on. Awesome.
You could please touch them, get a feel for them, look at it. So that way, when it comes time in an emergency, oh, hey, this is a Jackson raise. Hey, I can put this here. I know where to attach this.
And if all else fails, reach out to you guys.
Yes,
You guys are
calling
available.
anesthesia.
Yep.
Yes.
All right. Thank you so much.
Thank you.
Thank you.